Welcome to the Dizziness Summit. We're here today with Dr. Bill Anderson, who's a lead clinician at the Neurologic Wellness Institute in Wood Dale, Illinois. Dr. Bill specializes in functional medicine and treats many patients with dizziness, a little more unique in our clinic compared to other doctors. So I wanted to take the time today to talk to Dr. Bill and try to really understand what he does every day with patients that he sees. So thank you today for coming, Dr. Bill.
Thank you for having me, Dr. Traster.
So I know today we're going to talk about a term called dysautonomia. And it's my experience a lot of people have dysautonomia, but they don't know what dysautonomia is. And because it could come with a lot of different signs and symptoms, they go to all different doctors and specialists for each individual problem. And it takes a real specialist in dysautonomia to kind of put the pieces together and understand these possible underlying causes that can cause such vast symptoms that can be so different. And so why don't you tell us a little bit about what is dysautonomia and how you approach it, knowing that it could be so debilitating, but for different reasons for people?
Absolutely. So the autonomic nervous system is essentially everything your brain is doing that you don't have to think about. So it's controlling your heart rate, your respiration, and things like that. When you look at things that would affect that, just in general terms, when your brain is not working as efficiently as it should, that's one of the key signs. So it can throw off your autonomic regulation. So for that, you have to take a step back and say, well, why would that be happening? One of the conditions I treat is called Chronic Inflammatory Response Syndrome, which the acronym is called CIRS. And that has some severe cognitive effects associated with it. In general terms, we're looking at people that have a reactivity to what are called water damage buildings. So that can be, say, a roof leaking or a foundation leak. It can also be problems with plumbing or elevated humidity levels. And there's a subsegment of the population, about 25%, that have a genetic marker that we can test for that predicts that you might not work. Your immune system might not recognize the toxins that are produced very effectively, and that can lead to some excess inflammation, which can affect the cognitive abilities, and then also throws off the regulation of certain hormones we can talk about today.
Okay. And so when you have someone present to you and they tell you, I'm dizzy, and there's so
Right.
many reasons to be dizzy, why don't you start with a little bit of your thought process as far as, if I'm your patient, how would you start talking to me and start investigating why I'm dizzy?
Well, the first question is describe it without using the word dizzy. So, you have to look at different kinds of vertigo. Mm-hmm. Is it such that, when you stand up from a seated position or get out of bed, does your heart rate elevate and then you get lightheaded and want to fall over? As you know, there's like the BPPV, that could be more of a positional thing. So really the history is a key component when someone says they're dizzy as to teasing out, okay, what are the root causes?
And have you found in your experience with people who have chronic inflammation, or CIRS especially, do you find they have a specific type of dizziness, or do you find that it's all individual?
So in general, people will have that situation where they stand up when they get out from a seated position, they'll get lightheaded. That's one of them. Now they can have vertigo as well. So it can be, they feel like they're spinning or it feels like the world is spinning. And that really gets down to, okay, what part of the brain is affected from the condition? So the history forms will tease that out. So we'll make a person describe their dizziness, again, in terms without using the word dizzy, and then also look at some of their other symptoms that they have involved as well to see what could be driving it.
And as far as investigation, if I came to you and I said, I get lightheaded every time I stand up, I feel like my heart is racing. I might even notice, when it gets hot out or if it's humid, it's even worse, or in hot showers, it feels worse, or if there's pollen in the air, my symptoms exacerbate. And so how would you start to approach trying to figure out the underlying reasons of why I have that?
Well, so in regards to the CIRS, the intake form would differ. There's 37 symptoms that are really strongly associated with this condition.
Okay.
And if the only complaint is dizziness, then it's not CIRS.
Okay.
CIRS will affect you on a global level. So those 37 symptoms are broken down into 13 groups or clusters, and typically people have symptoms in 8 or more of those clusters. So if that's the case, and it often is, the next step would be to do what's called a visual contrast sensitivity test, which looks at the ability of the retina to detect subtle differences in shades between gray and white. And that was a test developed back in, I believe, it was the 90s by the Air Force for biotoxin illness in soldiers. So it's not 100%. It's really just a screen. It's very easy to do. And then if it looks like you have the symptoms associated with CIRS, and if the visual contrast, especially if that one's positive, the next thing would be to look at blood work. The antidiuretic hormone is one of the markers that we run on our blood work in this case. And what that is the brain will produce, it senses the level of osmolality in the blood, which is sodium levels in essence. And when those go up, it should produce antidiuretic hormone, which will make one hold on to fluids. So in essence, to thin out their blood. This is one of the main markers that it's almost so commonly disrupted in my patients that when it comes back normal, I'm surprised. So it frequently will just say it's not detectable. The lab will say less than 0.8. And if that's the case, I can pretty much tell someone you're thirsty all the time. And no matter how much you drink, you always seem like you're dehydrated. And as soon as you drink something, you end up going to the restroom very shortly thereafter. In really bad cases, people will also say that they get shocked all the time. So they grab door handles, they go to get in and out of their car. And what that is sodium's not being excreted through the urine, so it ends up going through the pores of the skin, and it almost makes someone like a battery. Wow. In severe cases, people will end up frying their watches, their electronics, TVs, things like that. People think they're told it's a psychiatric thing, and it's not. It's a physiological thing.
Wow. And that brings me to my next point is if I have, let's say, lightheadedness, what other symptoms do you commonly see with CIRS that might make me want to go get some of this blood work done, that maybe I should get more investigation? It's not just some simple dizziness that might go away over time.
Absolutely. The two big ones are fatigue and then brain fog.
Okay. Those
are almost universal in CIRS patients. So there's that. A lot of it's things that really seem odd. So it can be numbness and tingling, and it's not really in a distribution of a particular nerve, and it can actually move around from place to place in their body to where no one can figure out, well, what would be causing that. There's no condition that causes numbness in your right hand one day and then your right foot the next day. Aside from that, I mentioned the urinary frequency, going to the bathroom all the time, that sometimes it's hard to incorporate new knowledge. You can get headaches. Headaches are really common with the antidiuretic hormone being off. And especially if you take a migraine that doesn't last like 6 to 8 hours like a typical migraine, but we're talking like one that lasts for 36 hours or days on end. That's a sure sign that you have low blood volume being a driver of the headache. You can have memory impairment, decreased word finding, joint pain, morning stiffness. There's a whole host of symptoms that go along with this. And again, these seem like they're random, and that's why people have a really hard time getting diagnosed a lot of times, because there's no condition that causes all these that most people know about. There actually is.
So let's say I have CIRS or I have dizziness and I have brain fog and I'm fatigued and I come to see you. What kind of therapies or what kind of treatments are out there that you offer that might be able to help me?
Well, so the most important thing is getting the correct diagnosis.
Okay.
So the history is obviously a huge part of that, asking the right questions, getting the labs performed. We do have labs performed at our office every Friday morning. So all those markers are run, if that's what looks like the case is. So it looks at that genetic predisposition, and that's present in almost every single patient that I have with this condition, without exception.
Okay.
It takes about 3 to 4 weeks to get those results back, but it'll show elevation of some inflammatory markers that are pretty specific to CIRS. And it's kind of an alphabet soup of TGF beta 1 and C4A and MMP9. So a lot of these will be elevated, and that's really what's throwing off the brain's ability to regulate these regulatory hormones like antidiuretic hormone, and that's what causes a lot of your symptoms.
Okay, and then when it comes to what's causing CIRS, I know there's two main thought processes out there. There's one thought process says it's a chronic inflammatory disorder, and we've got to really control the inflammation. There's another thought process out there that says there's something underlying causing the inflammation, and we've got to really try to identify the triggers that are causing inflammation. And then some people try to do both and combine the two and try to reduce the inflammation in the immune system. At the same time, try to figure out what are the underlying triggers that might be causing the immune response. So how do you address someone who might have multiple reasons of causing their problems, and how do you address it from a multifactorial standpoint?
That's actually the most important thing, in my perspective, is finding what the triggers are. If it can be the home a lot of times, and for that you have to do testing. There's specialists in the area that can do that. You don't want to just call any mold inspector up and have them come to your home, because you're probably going to be told everything is fine. Now, if they do find mold, it's a really big issue. But there's a man by the name of Larry Schwartz, who he uses some of the more sensitive tests that look at, it's actually taking dust samples throughout your home. And he has a lot of different equipment like moisture meters and things like that to see, again, what the trigger is. Now, actually, it's not even really mold in many cases. It's bacteria called actinomycetes or endotoxins that can be the big drivers. So that's another thing. If you test your home for mold and it's not mold, it's bacteria, then you'll really never find out. Schools are another big exposure, because I don't know about you, but every school I've ever been in has a flat roof, and when it rains, you see water on the ground. So anytime you have water that sits there for 2 days or more, you're going to have growth.
So Dr. Bill, I know one question I get asked a lot is people are very concerned about living in a house with mold. And the question I always get asked is, do I have to leave my house? Do we have to move? Do I have to burn my clothes? Or is this something that I can deal with and work with in the house I already live in? So Dr. Bill, I know one question I get asked a lot when it comes to mold illness is, do I need to move out of my house? And there's a lot of people who are looking to maybe take drastic decisions in their life to get away from moldy environments. So how do you as a doctor differentiate when someone has to leave their environment and move out of their house versus when people can actually work and get better within the environment they're already in?
Absolutely. So that's a two-part answer. First, we have to look at what their labs are, how bad their symptoms are, and then I put that together, and I will actually share that with the inspector that we utilize, and he's able to better give patients advice in that regard. Because, I don't know, I haven't been to the patient's home, so I don't know exactly how bad it is, and that's really all he does. So as an inspector, it'd be a conflict of interest for him to do the remediation. So what he will do is help guide it. He will say, here's some contractors you can use. And typically what patients will do is they will contact those contractors, get an estimate, and then they can make a decision financially if it's worth it to stay in the home or leave. That is the number one thing that holds up people with this condition is continued exposure. Because no matter what I do, if they're living in a house or working in a place where they have continued exposure, they're not going to get significantly better.
So I'm going to ask a question as if I'm a patient now.
Sure.
And what I want to know is, I've listened to your talk, and I know I need to see someone trained to look at my history, maybe look at where I live, maybe do some blood work. But without doing any of that, are there certain nutritional advice? Is there certain supplements? Are there certain things that you found successful that you can give general advice for someone who might think that they have this chronic inflammation going on causing their symptoms?
Right. There's a lot of information out on the internet about binders,
Hmm.
and sometimes they work and sometimes they don't. So I'm talking like clay and charcoal, things like that.
Hmm.
A lot of times that'll cause a symptom flare. What I will typically do with patients is start them out on fish oil, a pretty high dose fish oil, for a week before we get into any binders.
Okay.
For the binders, I will refer out. There's two prescriptions, Welchol and cholestyramine, that we utilize. And what those are, they're called bile acid sequestrants. So your gallbladder, or your liver makes bile, it gets placed in the gallbladder and then dumped into the small intestine to help absorb fat. The toxins that are associated with mold and bacteria, they get bound by the liver, put into the bile, and then they go into the small intestine, and then they get reabsorbed in a lot of people. So one thing that people can do, especially if they've had their gallbladder removed, is there's a product called Bilamin, which will thin the bile, and that helps to promote the flow and they can help with fat digestion and also help get the toxins into the intestinal tract where they can be reabsorbed by binders. So those are two of the general things I'll do is Bilamin and then high dose fish oil.
Okay.
And then from there, again, it's prescription, so we really need to make sure that we know what's going on before we make that referral to either the primary care physician or a MD that we work with.
Well, thanks so much for talking today. I know I work with a lot of patients with dysautonomia, and we have great success, but there's some patients where there's nothing I can do from a neurological rehabilitation perspective to get the results I want. And I know very quickly on my end when I have to refer to someone like you because there's an underlying inflammatory condition causing the problem. And so I think that becomes the difficulty is there's so many reasons people could have these symptoms, and there's really no cookie cutter protocol. It comes down to really identifying the cause, the triggers, the underlying mechanisms, and really doing things very specifically for treatment for each patient. So I'm very appreciative of what you do because there's some patients really that need your help because without this type of care, they're really in a very tough cycle that's extremely difficult to get out of.
Yeah, thank you very much. And I've seen that over the years is the functional medicine, the functional neurology just work so well together because sometimes the patient has just one aspect of it and sometimes they have both. And there's some real magic that can happen between the two treatments if you get it right.
Absolutely. The nice thing about the nervous system is it connects to everything and controls everything. Sometimes the not so nice thing is that everything can impact the nervous system for better or worse. And so when you start looking at this chronic inflammatory conditions, you can present with neurological conditions, be sent to a neurologist for neurologic findings, but yet the underlying problem could be from the immune system. It could be metabolically from other systems, digestive system, the liver like you talked about. And so just because someone has quote unquote neurological symptoms doesn't always mean the treatment is straightforward. And sometimes you've got to really look at the big picture, like you said.
Absolutely.
Well, thank you so much. I really appreciate the talk today.
Thank you.